Welcome to the RX class. I'm your host, Dr. Guang Chen. Today I have another very special episode with a good friend and colleague, Dr. Ziggy Ye. Dr. Ziggy is a general and colorectal surgeon practicing in Sydney, Australia. He is specialized in open and minimally invasive surgery in the treatment of general and colorectal conditions. Ziggy completed general surgical training in Sydney and was awarded a fellowship of the Royal Australasian College of Surgeons. He undertook further specialty training in emergency colorectal surgery, as well as robotic surgery and pelvic surgery. A quick disclaimer before we begin. Please note that throughout the podcast episode, the information presented is general in nature and used at your own risk. Complex concepts may be oversimplified for entertainment and educational purposes. Symptoms and medical conditions, as well as the diagnosis and treatment of these conditions, may be mentioned. The information presented do not constitute practice of medicine nor replace medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health professional if you have concerns or symptoms. Please enjoy my conversation with Dr. Ziggy. Do you want to tell us a bit about yourself, Ziggy, and how you came to become a colorectal surgeon and with robotic specialization?
So I finished my fellowship in 2003. Then I went overseas and also do some local Australian fellowships. And I think during the fellowship year, I really enjoying the advanced robotic surgery. So I went to Singapore purely try to learn that. But in the same token, the Singaporean teach me a few other things that is quite interesting in colorectal surgery. The things about robot at the time, there are few generation of robot, and at the time I think it's the third generation, so it's not easy to be used as just a junior consultant and try to use that. And also there's a lot of learning in terms of where you need to put a robot to do your operation. So there's a lot of learning curve. And until I came back, and then I got introduced into the fourth generation new robot. It's called Da Vinci Robot XI, and it actually changed that entire sort of scenario. And the thing I love about it is it's like you're operating on a patient with your hands within the abdomen. So traditionally, if you don't do open surgery, you do the laparoscopy surgery. It's like you put in a straight instrument, like you use a chopstick to try to grab the organ, and you have to manipulate your chopstick direction to try to operate. And with a robot, it's really like your hands inside the tummy, and you can manipulate the organ the way that you want it. And it's actually quite interesting.
Ziggy, we might stop you there for a bit, for listeners who might not know what surgery is all about. But perhaps, let's use a simple example, and then you can describe what traditionally surgeons would do with what we call an open procedure, and then obviously later developed into keyhole or laparoscopic, and then the new Da Vinci robot. So, let's maybe use a simple example of a common operation that you do. Is it maybe an appendix or a gallbladder, and kind of we run through what these three different modalities would involve, and how each are slightly different in terms of benefits and the disadvantages.
Right. So the traditional open surgery, don't get me wrong, is very good surgery, but just in terms of how the surgeon put the hand into the abdomen is what we call surgical access. You need to have an open cut for the surgeon to see the internal organ. And once the surgeon sees the internal organ, we need to have enough access to put our hands or finger inside to operate and to remove the organs that you want to remove, or the diseased part of the organ, at least. So traditionally, in terms of abdominal surgery, you have to go through layers of tummy muscle. So when you go through the tummy wall, that's where the pain, recovery, scar can become a problem in terms of part of recovery process. As a modern surgeon, we still use that if we cannot do other minimal invasive way or any other procedure that can minimize the cut. But it's still a very effective way to do surgery. So give you an example of doing the appendix operation. Traditionally, we make about 10 centimeter cut in the right side of the tummy. And once we make that incision, then we need to go through layers of three layers of muscle and open up the abdomen and put a retractor, a device to keep the wound open. And then we put our hands and other instrument inside to remove the diseased appendix. During this process, sometimes the incision need to be enlarged if you are bigger patient or you have worse pathology than what we anticipated. Then about 30 years ago or 40 years ago, we start inventing the laparoscopy surgery. What I do is that we put a camera through what we call laparoscopy port. So it's like a straw, and you put instrument through the straw. And we use that camera to look at the organ. And during the time that when the straw put in, we put air inside the belly, so the belly get blow out, so we have a space to operate. Then we put a laparoscopy instrument. So normally, I describe like a long chopstick, and the front part can open and close. And we use that to grab in the organs. And some of the instrument got a Caesar on top, and some of them got a what we call advanced energy device. So we got a Caesar that power with very smart electrolytes. So they use those instruments to take out the organs. So you do need other for appendix. I typically do another 2 little ports. So total of 3 ports. One for camera, two for my hands, left hand and right hand. And we use that to take an appendix out. So if it's a very straightforward acute appendicitis with 3 ports, the biggest cut will be about 1 centimeter, and the other 2 will be about 5 millimeter. And after surgery, you don't have to go through that length of muscle recovery. So patients generally get better much quicker. Then why do we move to robotic surgery? So appendicitis usually is quite simple surgery. So imagine we use a keyhole surgery doing the bowel cancer surgery. Then bowel cancer is usually about 20, 30 centimeter piece of bowel you have to remove. It involve different area, and that's where sometimes the straight instruments will get stuck in certain portion of the tummy because there's other organs there, or there's a bony pelvis, there's a bone structure within the pelvis. You just can't get into that area. That's where the robotic surgery is very useful. And also, the robot surgery have very talented camera, so it actually magnify the structure about 10 times. So when you operate, it's not just that your instrument is better, your view is much, much better. And when I talk about robotic surgery, it's not that we ask a robot to do the operation. Just think about it. It's a machine that we place around the patient, not on the patient, but around the patient. And we put an instrument that go inside instead of a chopstick. Now the chopstick, the tip of it can move around and can move 360 degrees. So they itself become very manipulative, and the camera is much better. So we can have a total control of the situation when we're doing robotic surgery. And the incision, usually for more complex operation, you still need a bigger incision to remove the diseased organ. So for the bowel surgery, we still need to make at least about 8 to 10 centimeter cut to remove the bowel. But with robotic surgery, the incision can get much less. So if I typically make about 5 centimeter, but it really depends on the situation. Some surgeon with some situation, the incision can make down to about 3 centimeter. So that will enhance the recovery.
I guess can you tell us the actual setup? You know, how do you control the robot? Are you next to the patient? Are you sitting in a separate console?
Yeah, so the robot surgery has, I think, what we call 3 cars. So basically, there are 3 devices. Each device have it's like a tower. It's like a bookshelf sized tower, and one of them is called patient card, and that's the actual robot. That's typically all the video showing this car with 4 arms come out. That's the patient card. That's the one going to place on the patient. And you have vision card, which got the actual camera plugged into the central tower, and you have the what we call energy control. So you got your electrical knives and cutting device all connected to that. And you got a surgeon's card. So that's where surgeon sitting out, and we use that to control the patient count. So they all get linked with a very expensive HDMI cable. So all three machines get linked with HDMI cable. The cable, if you look at it, is really thick. It's compared to your home device, it's about twice bigger than your home device HDMI cable. And so therefore, you don't have a problem with the Wi-Fi dropouts or anything like that. That's quite important. And the patient card itself, when we do an operation, the surgeon need to make the initial access. So we still need to put a straw or robotic pore or laparoscopic pore into the tummy to blow the air. And once the air blow, we put a pore in the position that we want it. So typically there will be 4 robotic ports. And then we put we say we dock in a robot. So we put a robot against those ports and put an instrument through. That's how we call docking. And this is done by surgeons, me and my assistant and the nurses. And once the docking process finish, the robot will not move until the surgeon control it. And so it's very, very safe. So the surgeon then we unscrub. So we take all our sterile gown off, and we'll walk to our surgeon's console. We sit there, we start operating and control the robot do the operation internally. And the assistant will be sitting next to the patient. So assistant job changing the instruments, and sometimes to help us to so sometimes they have a little port for themselves to help us do operation. Usually if an operation is quite straightforward operation, the assistant normally just do a little bit of changing instruments only. They're pretty cool. So for the assistant and nurses, they normally sit down and start chatting. And for surgeons to do our job. Yeah.
And so are you kind of seeing everything through glasses, or you've got a computer screen in front of you?
So the Da Vinci robot has this. It's like you're looking through a computer screen through the 2 goggles. That's how I describe it. It's not actually a goggle, it's just that you put your head through this like a microscope type of screen, and you can see what the robot see. And your hands controlling on the patient's card. There's a 2 joystick, and you basically play with the joystick, and you will control all the 4 arms that are moving in and out.
And how many different types of accessories can you put in? You've obviously got some that grab, some cut, some sew. Is that right? In terms of the different accessories that can be.
Yeah, that's a very good question, Guang. There's a heaps. There are heaps of different instruments. So the robot surgery has been developed for the last 20 years. So all the instruments we see on the laparoscope, they almost replace it with robotic instruments. And some of the instruments are getting more smarter. Like for example, when I talk about energy device or advanced Caesar, the Caesar that will compress the organ and they coagulate or they stop the blood vessels, and they sort of cauterize the soft tissue, and then we cut it. Those robot instruments actually can know how much pressure they have to put on the tissue in order to generate enough sealing of the blood vessel. So it's more advanced. And the robotic stapler, so when we use like a stapler to close the bell and join the bell, the same thing apply. The staple will tell the machine how much pressure the stapler has been feeling, and whether they can cut through this or have to wait a little bit until the staple pressing down harder and to close it properly before it cuts. So it's a much better instrument basically. Yeah, and we got heaps.
And you get feedback when you're controlling the instrument. Do you feel like if you're pushing on something, do you feel it pushing back on you, or do you get some sort of pressure or biofeedback as you're cutting through different layers of tissue or some solid organs?
So I think the type of feedback I get, there are 2 different types. One, it definitely will feel that is when your arms cannot move. It's basically if you operate a confined space and the 4 instruments will come into the confined space, you feel the instrument clashing. So you feel like you get your arms restricted in terms of moving certain way, and that's where you feel your instruments basically. For the patient, so for my arm to fit in the tissue, unfortunately, compared to open laparoscopy surgery, the surgeon don't feel well for that. There's a new generation robot coming out, the fifth generation. I haven't ever had a chance to use it yet. It's in America. They actually put a biofeedback into the machine, so you actually can feel what you're touching. But in the fourth generation robot, the one I currently use, we use a visual feedback. So because I mentioned the vision part of the surgery become much better in the robotics platform. So when you're looking at a tissue, you actually can tell how much pressure you're gripping on. So you don't have a biofeedback on your hand, but you using your eyes to tell how much pressure you put on it. So it's a different way to operate. It takes a little bit used to, but once you get used to it, it's actually much safer operation.
Do you have a favorite accessory that you like to use on the Da Vinci robot?
Yeah, I do. It's my energy Caesar. It's called Vessel Seal Stand. Yes. Unfortunately, each instrument has its own life. So, say typical Caesar we use, I think you can use only 10 or 14 times before the instrument need to be replaced. So, because the way you operate the instrument compared to traditional surgery, it's like you have these wires that go into the tip of instruments. They got like many wires go through the tip of instruments to make it manipulate the way that you want it. So those wires get sort of worn off. So after about 10 or 14 times, they have to go back to the company and replace the wire. So that is the instrument fee. And for my favorite instruments, it's a single use. It's even worse. So it's quite expensive. We open it, we use it, and we have to dispose it. That's my favorite instrument. Yeah, I think I just want to say that this is like for Australian, we started about 20 years ago, but just because everything that when you started is new and there's a price tag, and I think at the time the price tag was pretty high. Like each time, I'm not talking about instruments. Each time you use instruments, the cost of instrument that will be divided by how many life of the instrument has, and that will be passing down to the patient, the consumer. So patient need to pay quite a bit of instrument fee, and I think that's why patient initially doesn't want to participate in robotic surgery. But 5 years ago, there are different robots that are coming up because the Da Vinci robot patent has expired. So they are about, to be honest, there are two other different robot platform is used in Australia, and there are 20 more overseas, and they all try to compete in the market. So good thing for the patient is the instrument fee now get absorbed through the surgeon and hospital fee. So patient doesn't have to pay for that anymore, which is good for the patient. And now it's just coming down to whether we can get more robot. Robot itself is quite expensive. Um, can't remember the cost. I think last time the rep told me if you want to set up a robot in a hospital, it costs about $8 to $10 million. So it's not very accessible to at the moment, but hopefully the price will come down and all the public patient. Now the robot is very available in private hospital, but not in public sector. If you have robot in public sector, you only can do certain procedures, but I think eventually it will take over the traditional laparoscopic instruments.
Yes, look, I mean, just to explain, in Australia, the health system is somewhat complicated. We may
Yes.
talk about this a little bit later, but now we divide this into a public and private health system. Within the public system, look, all patients have essentially equal access, and there's essentially no out-of-pocket cost for their surgeries. However, in the private system, it is a bit more complicated, and again, we may talk about later, but involves private health insurers, and there are sometimes potentially out-of-pocket costs for patients.
Yeah, that's correct. I think for public robot, all the major center will offer prostatectomy with a robot access. So it's actually quite a good platform for patient with prostate cancer that can undergo those operations. I think just unfortunately there are certain surgery that what we do for colorectal cancer is not readily available in public sector. But I do hope that will change eventually.
And where do you see, I guess, the major changes happening in the next 5 years? Do you see the robots getting smarter? Do you see better instruments? Do you see everybody using robots instead of traditional laparoscopic or open surgery?
Yeah, I think that's a very good question. I think 5 years down the track, let's talk about this year. Robot platform, they got two different new robot coming out. One, traditionally, when we do a very confined surgery, like say if we want the robot access through the anal canal, we actually can do surgery with a robot through small anal canal and working through the mouth. But you are docking a big machine next to the small orifice, so that just become very difficult because not just the instrument fighting internally, the instrument also fighting externally. There's not much space around that area. So there are two new robots come out. One is the one I mentioned, the new robot with better eye vision, uh, a feedback on the instruments, and the other robot is a very small, confined, single arm robot. So basically, instead of you see a traditional robot with on the patient card, you see the big a big tower with the four arms. This machine got one tower and just one arms. And when the one arm go into patient's orifice, it will open up, become four small arms. I think it's quite exciting. So you just need
Oh,
to
that is
put
very
one
exciting.
port, yeah,
Yes.
one little port, and it will open up. Just remind me the what's that movie called? Uh, Matrix. Remember the Sentinel come in try to attack the humans. All of a sudden, their tail become like so many arms. It's a little bit like that. Yeah, I think quite
Oh,
exciting.
that is very exciting. I guess
Yeah,
you only need a small access port, and then everything opens up internally.
yeah. So that's a new version. I haven't tried it yet, but I think it's very exciting. It's coming to Australia soon this year. So this is we just talk about this year. I think a few years down the track will be better robot, and hopefully with some competition coming out as well. I do hope eventually the robotic platform will replace the laparoscopic platform. However, I think there are some surgery we still can't do minimal invasive. Say, for example, if someone got bowel cancer, the bowel is completely obstructed, tummy is completely bloated like balloon. I don't think you can assess that through any robotic platform or even laparoscopically. That patient need open surgery. So I do think there is open surgery still a part of the surgical procedure that surgeon need to learn and need to do. And if possible, all the patients should have the robotic or laparoscopic surgery, but eventually um, the open surgery cannot be replaced.
I guess yes, for a bit of trivia, uh, let me ask a few questions. What glove size do you wear?
I use some. So traditionally, if I don't need to do a fine surgery, I use 7.5 and 7. That's quite interesting. So we normally wear bigger gloves.
Do you play music in the operating theater?
Yeah. Oh, depends on the surgery actually. There's what we call standard piece, like when you're doing colonoscopy, gastroscopy. For that, I'll probably play music. Um, but it's for like very complex surgery, you need concentration. I normally cut the music off. We play at beginning with very low volume, and when the surgery into a very complex part, I told them to cut the music off completely. Yeah. And then nurses really enjoy it. So I really think playing the music would increase the morale in theater.
And how do you get through a very long surgery? You know, if an operation takes several hours, how do you maintain concentration? Do you take breaks in the middle, or what happens?
Yeah. So in the old day when I'm talking about when I just first started, I normally don't take a break. And I think later on down the track, I realized taking a break actually is very important because you actually lost your concentration halfway through. You're hungry, and sometimes you want to go to the toilet and you really can't. So I think it's very important if we have a long operation. I plan the operation, so I normally say that into a certain part of operation, I normally break down into A, B, C, or even more complex A, B, C, D, E, F, G. But when we finish a certain part of surgery, and I think then I will ask my team to go for a break. So me, my assistant, and the scrub nurse will unscrub And we leave the patient in a very safe place. So we told anesthetists we're going to leave the patient as it is for 15 minutes. We ask the permission and make sure the patient's safe before we go 15 minutes. And for that 15 minutes, we normally drink, eat very quickly, go to the toilet. So 15 minutes, you do a lot of things. Yeah.
I know I think it's very important to maintain your concentration and to keep the team happy.
Yes, definitely. It's very important.
Okay, well, thank you so much, Ziggy, for talking today. We learned a lot about robotic surgery and the current climate, and as well as a lot of exciting developments to come.
Yes. Thank you very much, Quang, to me.
Thank you again for listening to another episode. As always, if you've enjoyed the episode, please subscribe on your favorite podcast player and give us a 5-star review. If you're interested in the Da Vinci robot, I've put in a couple of YouTube links in the show notes. There are a couple of exciting videos of the robot slicing a grape and also sewing it back together. If you've got comments or suggestions, please reach out to us. See you next time.